Hi, everyone. Before we begin, I'll just share a couple of procedural things. You may notice that the chat function has been disabled, but throughout the presentation, you can use the Q&A feature to pose questions to our speaker, which will be addressed at the end of the webinar. And if you run into any technical issues, you're also welcome to use the chat feature to reach out to myself or Jason, who are here to support. You'll notice that there is a survey at the end of the webinar. Jason will share that both in the chat and also via email, and we do hope that you take the survey to let us know how you liked the webinar and what you're interested in seeing next. You'll also notice that this webinar is being recorded. It will be posted to AVA's YouTube channel shortly, and you can revisit this webinar, share it, and also revisit our previous webinars. Once the webinar begins, I'll share the link in the chat to both our past and upcoming webinars. Welcome to the Alliance Against Violence and Adversity's Webinar Wednesdays. I'm your host, Dr. Sarah Yursich, and I'm joining you today from the unceded traditional and ancestral territory of the Coquitlam First Nation. And on behalf of AVA, which is national, I also want to begin by acknowledging that, on a national level, we encourage all Canadians and visitors to Canada to learn about the Indigenous peoples of the lands on which they live, work, or visit, and become engaged allies together. We, as Canadians, in the spirit of truth and reconciliation, respect the self-determination of First Nations, Métis, and Inuit peoples, and their rights and responsibilities in cultures, languages, and the pursuit of wellness. The focus of today's webinar is public health's role in preventing and addressing violence, insights from the Brazilian Unified Health System. We are joined today by Mayara Lewis from the Federal University of Espírito Santo in Brazil. She is a member of the Laboratory of Studies on Violence, Health, and Accidents, where she contributes to research on violence prevention and public health. Currently, she works as a nurse in the Violence Prevention Unit, and she also serves as a technical advisor at the General Coordination of Epidemiological Surveillance and Violence Prevention at the Brazilian Ministry of Health. Her work focuses on strengthening epidemiological surveillance to support violence prevention efforts. And now, without further ado, Mayara, I'll hand it over to you. Thank you for joining us today.
Thank you. Good afternoon, everyone. I would like to thank AVA team for inviting me to speak with you all about this topic, which is so relevant to all of us. And I received the invitation with joy. And I hope I can contribute to all of you who are here today. So I am Mayara, I'm Brazilian, and currently I live in Brazil. I could live in Canada for 6 months in 2021 under an exchange program, and I had the great luck of being supervised by Dr. Nicole Turno. And I could know a little bit about all the work she and her team is doing in Canada in order to address violence. So we have some partnerships going on right now. We've been doing a touch program here in our university, and the results have been amazing. So it's an honor for me to be here today. So I'm not going to introduce myself again. I'm going to start because I have a lot to say. And the first thing I'd like to talk about, to discuss, is how the Brazilian health system, specifically how our health surveillance system works to address violence. I've been studying, researching, and working on the topic of violence for a while now, since I was an undergraduate student from a public health perspective, and more specifically from the lens of health surveillance. And every now and then in meetings or during discussions, a question comes up from colleagues, people who work with public health, especially those who work with infectious disease. They sometimes ask us, why is violence a public health concern? And so I've learned that I always need to be ready to explain why this topic matters and why it needs to be part of our discussions. And the thing is, violence is still often seen mainly as a public security problem or justice problem, but in fact, it is a public health issue. So that's why the first point I want to make today is this, to help us to reflect on this, because while for many of us this is very obvious, the truth is it's not obvious for everyone. So To start, according to the data from the Global Study on Homicide published in 2023 by the United Nations Office on Drugs and Crime, the global homicide rate in 2021 was 5.2 in the world per 100,000 people, varying by region, as we can see from this image. The rate in the America continent was 15, surpassing rates in the other continents. And when we talk about suicide, according to the WHO in 2021, its global rate was nearly 9 per 100,000 people, which corresponded over 700,000 deaths in the year. And when we look at age groups, suicide was the third leading cause of death among people aged 15 to 29 years. When we compare the homicide rates of Brazil and Canada, the difference is striking. When I was looking for data to insert here, I was shocking because I know it was different, but I didn't know it was so different. So in 2021, there were over 45,000 homicide victims in Brazil compared to 788 in Canada. So, of course, I need to mention that Brazil's population is over 200 million people, which is 5 times larger than Canada's population. But still, the homicide rate in Canada was 2.1, while in Brazil, it was 10 times higher, 21.3 per 100,000 people. So this is a difference. So you can see from this data that in Brazil, this is not a challenge that is easy to be tackled. And when we compare Brazil and Canada's suicide rates, they are closer, right? In Canada was 8.1, while in Brazil was 6.9 in 2021. Violence is also a public health concern due to its high cost. So in 2019, the global economic costs of violence in the world, including conflict, homicide, self-harm, and prevention, enforcement, was estimated in 14.4 trillion US dollars. A joint of WHO and World Bank estimated that violence accounted for over 48 million disability-adjusted life years in a single year, and long-term costs for rehabilitation, mental health services, and emergency care also is a burden. But beyond costs and numbers, and although we try to estimate in numbers and money how much violence costs, its indirect costs and impacts cannot be totally measured, because violence is also a significant public health issue due to its psychological and emotional trauma. It can lead to mental health disorders and long-term health consequences such as chronic pains, disabilities, reproductive health problems, and an increased risk of non-communicable diseases due to prolonged stress. There are many studies on the literature talking about this, and we know that. And there are also intergenerational effects. So children who grow up in environments exposed to violence may experience development delays, learning difficulties, and increased risk of becoming victims or perpetrators of violence later in life. Violence also reduces social trust, fear of neighborhoods, and consequently social isolation, which affects well-being and social development. And exposure to violence can lead to a school absenteeism, lower academic achievement, and reduced cognitive performance in children and youth. So the question I would like to do, and that I always ask when I am training people or talking about this theme is, how different would someone's life story be if violence hadn't marked their path? So how physically, emotionally, mentally healthier will this person be? We know that many victims can manage to overcome their traumas and live healthy lives. which is what we as health workers we strive for, we work for. However, we also recognize that many continue to struggle with the effects of their experience for years, particularly in socially vulnerable contexts. So as I showed you the data, I think you can imagine how challenging it is to address violence in Brazil. So I'm going to talk about how the Brazilian Unified Health System, we call SUS, addresses this problem. So Brazil is a large country located in South America. It's the fifth largest country in the world. The country currently has a population of over 200 million people. It is made up 27 states and its federal capital, which is Brazilian, and our mother tongue is Portuguese. Brazil's Human Development Index is 0.789. This means that we have most people living in poverty and very few who have large amounts of wealth, which leads to a deeply unequal society. But it's important to highlight that we had a long period of slavery that lasted 300 years, which has resulted in deep social inequalities that persist to this day. So this legacy has led to structural problems, social problems that are challenging to address, such as violence. So I'm going to talk about SUS. SUS is the largest public health system in the world, providing health care for more than 200 million people. Its creation was a major achievement for Brazil in expanding access to services and in reducing health inequalities. It is guaranteed by our federal constitution. So after 21 years of dictatorship, in 1988, Brazil approved a new democratic constitution, which recognized health as a right for all and a duty of the state. So SUS was not given by the government. It was a conquest of the Brazilian people, built through the mobilization of academics, health workers, and social movements who wanted to make the country a country fair. SUS is definitely one of the most important political achievements in our recent history. And in 1990, with the Law 88, the organization and functioning of the system were defined. So I'm going to briefly explain a few principles so that we can understand how violence is addressed within the system. So the Brazilian Unified Health System is based on three doctrinal principles. Universality, this means that access to health services is a basic right for everyone, regardless gender, race, occupation, even nationality. If you go to Brazil, you can have access for free for health. If you are here for one day, even if you are here for one day, you can go to any health services public and you can have access to it. So this is a right that must be guaranteed by the state. The another principles is equity. The goal is to reduce inequalities by providing more for those who need more, ensuring that resources reach those who are most vulnerable. And comprehensiveness. This principle sees people as whole beings and addressing all of their health needs, and this requires integrating promotion, prevention, treatment, and rehabilitation, and it also connects health with other public policies. And beside these three doctrinal principles, we also have the organizational principles. I'll focus on three of them because they are important for us here today. So the first one is regionalization. So services are organized by geographic regions based on population, resources, and health needs. We have this second one. I swear I tried to say this first word in English, like the HIER word, but it's very difficult for us who speaks Portuguese to pronounce these words. So I'm going to say level organization during the presentation. So this principle means that services are structured in increasing levels of complexity, primary, secondary, and tertiary care, so that people can access care according to their needs. And decentralization with unified governance. So this means that responsibilities are shared among federal, state, and municipal levels. So municipalities are the main managers of local services, but with coordination and guidance from the higher levels. This is especially important for violence surveillance because the Ministry of Health defines the guidelines, and states and municipalities are responsible for implementing them, ensuring unified governance with each level playing a key role. So in summary, SUS is one single national system, and it offers a really wide range of services, all free at the point of care. We are not talking about only doctor's appointment or hospital care, but also vaccination campaigns, blood, organ, tissue transplants, HIV treatment, cancer care, and even the production and distribution of medicines and vaccines through public labs. So there are a lot of things that SUS is responsible for doing. And the way that the works is the Ministry of Health sets the rules, right? The guidelines, the policies, then state and municipalities are in charge of putting this into practice. They have autonomy to manage their local services and make their own organization, but are always following what was defined nationally. So my state cannot define something that is not according to what the Ministry of Health is doing, right? So that's how we keep as one unified system across the whole country. And I just want to highlight in the level organization principle something called primary health care that I believe you also have in Canada. And it plays a central role here, especially when we talk about violence. And I need to highlight the family health strategy, which is a model that provides free access to preventive and primary health care through multidisciplinary teams, including doctors, nurses, community health workers, and others. So these services are delivered in basic health units that we call here in Brazil UBSs. And this service works as the entry door to the health system. So primary health care is essential to address violence because it's close to the community and it can identify and support victims directly in their territory. So in Brazil, we have 5,570 municipalities, cities, and almost 45,000 basic health units is spread in the region. So population from Amazonas to the south of Brazil is covered by this strategy. And we also have health surveillance. I'm also going to approach this topic, which is the main topic of our discussion today. So health surveillance is a systematic approach. It means collecting, analyzing, and interpreting data, and then turning this data into useful information for decision making. It guides implementation of measures, and it needs to be monitored and evaluated over time. So in fact, health surveillance should be part of daily practice of across all levels of care, at the hospital, at the basic unit, health services, everywhere. Health surveillance should be implemented. There are many ways surveillance can happen, but the main one is through the analysis of reported case. And how is this information collected? So each country has its own notifiable disease list, conditions, diseases that must be reported by health professionals, and standards forms are used nationwide. So these lists are based on diseases or conditions that pose significant public health risks if not properly controlled. So let's say there is a suspicious case of meningitis in a school, right? So the child goes to the health services, but no health worker reports even that first suspicious case. And the case stays invisible. No measures are taken. Health authorities don't know about this risk, and the disease can spread quickly in the community. By the time it's finally detected, more people are already sick. We saw something recently on COVID-19, for example, of this how disease can spread very quickly, and the importance of health surveillance had to overcome the problem. So by the time it's finally detected, more people are already sick, and the response becomes much harder and slower, because when there was the suspicious, maybe the health worker didn't realize or didn't report, and this becomes more and greater and greater. So reporting diseases or conditions is what allows the system to respond, to act, to stop spread, and to organize care and protection. And that's the same logic for other situations. I told about COVID, about meningitis, but we can see it like measles, tuberculosis, HIV, syphilis, or even violence like here in Brazil. So how does this apply to violence? So the Brazilian Ministry of Health has a long list of notifiable conditions, I think around 60 diseases or other external causes that we call, that must be reported when there is a case that is suspicious or it is confirmed. You have something similar in Canada through the Canadian Notifiable Disease Surveillance System managed by the Public Health Agency of Canada. So I think you can simulate what I'm talking about. But the key difference is that in Brazil, violence is included as one of the notifiable conditions. So this means there are specific criteria that define when a health professional must notify a suspect or a confirmed case of violence to the health authorities. So as I told you, violence is a subject in mandatory reporting. It fits the notifiable disease information. It has two objectives, right? That it fits the notifiable disease information system that here in Brazil we call SINAM, and also to insert the victim into a network of care and protection. This slide is just to briefly show you that defining violence as a notifiable condition in Brazil was not something that happened overnight. It was a process built step by step through different laws, policies, and national guidelines. So each moment in this timeline represents part of the construction until violence became formally recognized as something the health services and health workers must notify, just like any other major public health issues. So we are going to look at SINA's data, some data, but first I'd like to briefly explain about the case definition. So every disease, every condition that are in this list, there are specific criteria that must fill to a health worker notified. So as case definition, we notify every confirmed or suspect case of violence against all men and women in all the life cycles, when this violence is domestic, when it's sexual violence, legal intervention, self-harm, human trafficking, torture, work analogous to slavery, child labor, and LGBT violence. What do we not notify is men aged 20 to 59 years who do not have any of the conditions mentioned above. So let me give you an example. Here in Brazil, we love football, like soccer. And sometimes people get into arguments because of this. Maybe like you with hockey teams and everything, but here people they fight. They punch each other because of this. So this is very common. But when this is happening between men against men, and it's not related to any of these contexts that I stated before, we do not notify. Or here in Brazil, we have a problem with drugs, right? So gangs, they fight against each other. So with two men, they fight and against each other. Because of this motive, they will not be notified if they look for a health services. So we have another systems that take care of this part. So our system, the reporting, it's not for this purpose besides this one. And this is a lot, like domestic violence is a lot, sexual violence is a lot, but only these conditions, under these conditions that we do not notify. So what data do we collect? So the form, we can collect a lot of data on the victim, the characteristics of the occurrence and the perpetrator characteristics too. And we also collect data about referral information. So as you can see, the number of reported cases of violence has been increasing every year. I analyzed only from 2014, but it's been increasing since 2011. The only exception was in 2020 when we saw a decrease, most likely because people accessed health services less during the pandemic and therefore fewer cases were identified. By 2024, we had over 600,000 reported cases, the highest number so far. And this shows that our efforts to give visibility to the problem and to the victims are working. Here, I just want to share a little bit about who are the people we notified so far. So in 2023, there were over 500,000 reported cases. Human made up the majority of the cases, 71.4% of the total. And this is because of what I told you before, that we do not notify men and everything. So it's expected that human would have the largest proportion. Children and adolescents up to 19 years accounted for 36.2% of the cases. And when we look at race, more than 57 of the people who reported were identified as brown or black. Brown or black is how we classify race and color here in Brazil. Oh, wait. Here I just want to share a little bit about who the people notified are, as I told you, but also what type of violence they suffer. So according to the data, about 30% of the cases were self-harm and 67% were interpersonal violence, and physical was the most common, and then negligence, especially against children and elderly, and then sexual violence, psychological violence, and then other types of violence. So here I want to talk about violence, approaching violence by different levels of management. So each level plays a key role in violence surveillance. And now in this topic, we can see like the decentralization principle working very well. So the Ministry of Health, the Ministry of Health defines policies and guidelines, coordinates with other ministries, actions, intersectoral actions with other ministries, provides technical guidance and to states and municipalities, and standardized flows and reporting. The state health departments adapt national guidelines to regional realities, support and supervise municipalities, strengthen intersectoral actions in their territory. And municipal health departments and services identify and notify cases. So at the municipal level is where everything like happened. The care happens. So at the municipal levels, we are responsible for identify and notify cases, implement care and protection networks, and deliver direct assistance to victims. So I'm going to briefly explain how violence surveillance works in practice, or at least how it should work. But because of challenges we are approaching later, this doesn't always happen, but this is something that happens in many places, but not in all of the cities in Brazil. So when a person goes to a health services as a suspected or a confirmed case of violence, health professionals are mandated to report the incident. So this reporting involves completing a form, like I told you before, standardized by the Ministry of Health for use across the entire country. Once filled, this form goes to municipal health department with two objectives. The first is mediate action, so activate a care network to protect and support the victim, which includes mental health, social, and legal services. And for data collection, that is entered this report into the CINA, that is the notifiable disease information system, that enabling epidemiological analysis and the development of public policies. So I'm going to talk about how this works in the city where I work at the Municipal Health Department. I work in the NUPREV team, which stands for the Violence Surveillance and Prevention Unit. And here it's important to recall what I told you about decentralization, because states and municipalities have autonomy to implement their own rules as long as they follow what has already been defined by the Ministry of Health. So nationally, the law says that only health workers and health services are required to report violence, but in my state, there is a law that also obligates schools, social services, and the guardianship council. This is the translation I found, but it's here in Brazil is the organ who protects like children and adolescents when their rights are violated. I don't know how you call in Canada, but here we call something similar to guardianship council. And all social assistance services to notify cases in SINA. So nationally, only health workers are mandated to notify, but here in my state, we have all this source of reporting because of the law. So this expanded the number of sources of notification and consequently the number of reported cases both in the state and in Vitória. So in 2024, we had over 3,000. I have a problem to speak numbers in English. Sometimes my brain doesn't work very well, but we had over 3,700 cases of violence reported in the city where I work against or within like self-harm, violence, interpersonal violence within people who live in Vitória. And we in the NUPREV team, we based on information from electronic health records and based on the previous notification, when the victim has already been notified previously, we receive the cases and we analyze case by case, and we send individual reports to the primary healthcare service, mental health, and social protection network to recommend actions that should be taken in order to protect and care for the victim. So it's a lot of information that we process. Our team is small. We are located Vitória City Health Department under the epidemiological coordination. Our team, two nurses, me and another colleague, one psychologist and one social worker. We also have some undergraduate students and postgraduate students that work with us. And this is our main we do more things I will show you, but this is something that we do, like reading case by case that we're notified, and then checking the information on our information systems. And if this person is not being seen by health, it's not cared by health services or legal services, we send reports to everybody and every services that should know about this case. And we talk about this, and primary healthcare is very important because it's where this the care will actually happen and delivered for this person. So surveillance acts like an articulator between different sectors, integrating different actions in the territory. So we also do more things than that, much more ongoing training, workshops, technical notes, recommendations. We are always training people about what violence is, how to recognize warning signs, how and when to report, how to notify, referral, connecting victims to care networks. So we do not get in contact to the victim. I don't see them. I only read the electronic health information, but we make all this referral movement to connect these people. We connect to the health workers, right? And also to the social services, but we do not connect with the victims. But we, in very moments, we make these people being cared, right? We also ensure protection and support because sometimes who are there at the basic health units working, like the nurses, the doctors, they have to deal with so many things at the same time. But when we who are dealing with violence all the time, we open the information and we see some things, we can say to them, we can alert them, and then they can take actions that actually will make difference in the person's life. So that's how we work. We also have research and academic partnerships, collaboration with the university, especially through UFES and LAVISA. Teaching, research, we do a lot of research together, community outreach projects, innovation, and everything to strengthen violence surveillance. We also disseminate data and help decision making because as we analyze the data, we have this information necessary to make changes. About challenges and gaps. So there are many challenges and gaps. Like we used to say, SUS is beautiful. I mean, SUS is, like I told you before, is a conquest, but there are many challenges and gaps that we still need to overcome. And when we talk about violence surveillance, I will present few specific. So, for example, a lack of technical knowledge among workers and students. This is a problem we have here in Brazil because we do not learn about this during the undergraduate. So people, they graduate without even know that violence should be notified. So this is a problem that we need to deal. Gaps in information systems and electronic health records. Now this is changing a lot, but I think this is one of the worst challenge we have because everybody has its own information system. So health has its one, like many of them, and then social services, they have their own information system, but they don't talk. So sometimes we don't know what's going on social services to protect the victim because we only have access to and the systems are not integrated. So this is a problem. Limited human and financial resources for surveillance, weak intersectoral coordination. Here in Vitória, this works very well, but we know this is not the reality of most part of the cities in Brazil because of the regional inequalities in infrastructure and technical capacity. And this causes underreporting and visibility of cases, low data quality. So the forms come for us incomplete or inconsistent, and this causes another problems. Difficulty translating data into effective public policies is also a huge problem we have. And in the end, victims without timely access to care and protection. So this results on this. Weak intersectoral response networks, perpetuation of cycles of violence in communities, reduced public trust in health and protection systems, and limited capacity to evaluate risks and prevent violence effectively. So, part of the solution I would like to talk about is cross-sector strategies to address violence. Of course, there are many solutions we need to implement, but I want to highlight this one. So cross-sector strategies are essential. And to start, we need to map our territory, identify people, institutions, and services that already are working with violence or not, and that can help us strengthen our efforts. I worked as a nurse in the hospital epidemiological surveillance department of a children's hospital here in my state. And when I realized how many cases of violence were going underreported by health teams, I started thinking about how to increase the capacity of surveillance to capture these cases. So I went to the IT team, those generalists, like shy people work in a cold room full of computers. And I realized I needed them to help me create a simple but effective system, one that I could give me reports and make surveillance more sensitive, so I could detect case and not notified by the hospital health staff. And they helped me improve the system I was using. So I went to them, talked to them, and they didn't know anything about violence, but I didn't know anything about system, but I was trying to understand what they had, so I could use what they had to my work. At the same time, I was working with the psychosocial team, thinking strategically about how to better organize care for victims inside the hospital. But I was also working with people outside the hospital to understand how referrals could be improved. So we talk a lot. We talk to everyone, those who are interesting, those who are not interesting, but that can help us. And I even made a great partnership with the hospital's public relations officer. So there was a lady, she was responsible for spreading information, talking to the social, to reporters and everything. Together we thought about how to spread information across the entire hospital team, not only about violence, but also about other notifiable diseases. And she helped me even to organize trainings and a seminar that later we held at a local university. So we did a lot by talking, right? This is an example inside the hospital, but we don't need to be inside a hospital. We can do this anywhere. So the lesson is we need to talk, to reach out, to think outside our box and expand partnerships. People will join us if we show them why this work matters, why notify matters, why to report matters. People will join us, and we are open to if we demonstrate that we are open to work together, they will cooperate with us too. So another thing I've been learning from people who have worked with Valor much longer than I have is the importance of knowing how to wait for the right strategic moment to act, and establishing agreements and shared responsibilities sometimes takes time, because it's all political, right? So we need to sometimes just wait for the political moment to be right so we can establish these agreements and share responsibilities. Collaboration should involve students, researchers, workers, and managers. Finally, let me share with you something like a Brazilian slogan that we always say here. All Brazilians, we always say this. I think we born like saying this. We are Brazilians, we don't give up. So we always say this when we face a challenge that seems bigger than us. We don't give up. We try again and again. We keep going until we get what we want. That's why I like to say we are not stopping until we have a better country to live in. I wish we had conditions like you guys have in Canada. You have a way better quality of life than we have here in Brazil. And I know this will take a long time due to structural problems, social problems that we have here, but we cannot give up of providing people access to healthcare. We cannot stop until people being protected. So I always think that violence will keep happening despite all of our efforts, as it happening everywhere in every country. But I truly believe these numbers can progressively decrease. So we cannot save everyone, but we can save many. So I often think about children, especially children that we see like so abused, and adolescents and other vulnerable groups who come to our services showing clear signs and symptoms of violence. And too often we let them walk away unnoticed without any assistance. And this is what we cannot allow anymore. And I think this is what I work for. So what we must commit to and never give up on is making sure that in Canada, in Brazil, or wherever people are, is when these people come for us in our health services, in our social services, they will not go back to their homes or to their suffering in silence. We will see them, we will protect them, we will offer them everything they need to strive. So thank you very much. I'm here for any doubts. I hope I could share with you something. And yeah, thank you.
Thank you so much, Mayara, for such a fabulous presentation. I know I learned so much, and I imagine that our audience did too. For those of you in the audience, please take a moment to form some questions, put them in the Q&A, and you'll also notice on the screen that there's a QR code for you to be able to take the survey. So, Mayara, during your presentation, I spent a lot of time kind of reflecting on all the really important things you were saying and the idea of that shift to a public health approach and something so important as violence surveillance. And I know there are many countries around the world who aren't quite there yet. So, for folks who are interested in implementing a public health approach or doing something really powerful like the pieces that you talked about, what are a few steps they can engage in to begin this work if they haven't already started it?
Can you repeat the question, please?
Yeah, I'm just wondering, practical steps for folks who don't quite implement a public health approach to violence prevention, for example. Are there a few practical steps that people can start implementing in their work to shift to that public health approach?
So I think this is something that Brazil has like as a law. I don't think you have in Canada, right?
Yeah.
Like violence, like a subject of health surveillance. But this is something that should happen in a large scale. But yeah, this is not under our control. But I think to strengthen, like in our health services, like the thing that I would do probably would a step that I would take would map where are the violence cases entering in my services and when are they leaving. So, for example, in emergency care, this person comes first for a evaluation and everything. So I would go after this point to see to identify at this point the victims, and then people they leave the hospital. I would go to the sector where they live to see if just to check if the person was seen because of violence at some point. I don't know if it answers, but I just to map the places and the services where this person goes, and then implement health surveillance there, like in through health information systems or talking to people to think about strategies. I think this is so local sometimes, but steps by talking, I think is the key.
Yeah,
I don't know if I
absolutely.
answered you.
No, you absolutely did. That was so helpful. That was so helpful. Thank you. Because even here in Canada, I know when you've been here and you've worked in this context, is a lot of what causes risk for survivors of violence is that people don't communicate. And I think mapping
Mhm.
is a very good way to start to do that. We did have a question come in from the audience. The question is, does Brazilian unified health system protect individuals from situations where reporting violence might put them at risk?
Reporting violence might put the victim or who is reporting?
The victim, yes. So, like, if there are situations where reporting violence might put them at risk, are there protections in place for that? If coming forward,
Yes, yes, there is. Yes, there is. Actually, this is a discussion we have here because sometimes people, for example, I'm a nurse, I work at the hospital, and sometimes a friend of mine come to the hospital because her husband um, has abused her. And sometimes people they fill the form and they send like photos. This has already happened, exposing the victim, exposing the perpetrator. So this is a challenge. A challenge we need to take care every time about the privacy of the victim. But mostly when these people are reporting and their lives are really dangerous, we have places to put them. So we need to take care as health workers because of ethical. Sometimes it's a problem. Sometimes people they don't think what they are doing, and they by filling the form they are putting people's life in risk, right? But yes, we have legal ways to protect a victim instead of exposing them.
that's great. Thank you for that. I don't see any other questions coming in, and I know, much like myself, I think people are really processing this because it's such important work you're doing. And Ava and I both really appreciate you taking the time to come and share this knowledge with us. Your time and your knowledge are so important and needed. So thank you so much, Mayara.
Thank you, everybody.